Good morning, everyone. I'm going to talk about our program for gynecologic cancers. So we have 4 members of our division, pure gynecologic oncologists. We do work with our radiation oncologists, our medical oncologists, but as the GYN oncology division, we have 4 members, and it's the largest division in Brooklyn. We have complementary skills. Not all of us do exactly the same thing, but we work very well together. Dr. Diver has a long experience of running clinical trials at Stanford. She came to us and sees patients in ACBR in Bay Ridge and gives chemotherapy to our patients. Dr. Catherine Herman was really our star fellow at NYU and literally could have gone anywhere in the country. We were very happy when she decided to join us in Brooklyn and be part of the work we're doing. She is one of the few that gives chemotherapy, does surgery, and she'll be in charge of building our clinical trials program in Brooklyn. Dr. Marina Stasenko, highly experienced surgeon, also gives chemotherapy, and she's also sees patients in Manhattan and operates in Manhattan. So just following the same theme we had today, is not only that you may get physicians of the similar quality or have the same services, you can also many times see the same physicians in Brooklyn and in Manhattan. And I'm the lucky one who gets to work with all these great physicians. The same themes we spoke about today, no matter how good are your doctors, if your staff, your office dynamic is not ideal, there's frustration for the doctors and for the patients. And I cannot say enough about how well is the office staff we work with. It's really an extremely well-oiled machine. And I've been in a few places before coming to NYU, and I've never seen such dedicated team with an exceptional work ethic. We have 2 nurse practitioners. One just finished her doctorate, and she is going to be dedicated. Currently, she does a little bit of everything, but she's going to be dedicated to perioperative care and survivorship. And we have just recruited a 2nd nurse practitioner who's going to be solely dedicated to patients receiving chemotherapy, helping them before, during, and after their treatment. And she'll be working with Dr. Herman closely to build our clinical trials offerings in Brooklyn. She was a nurse for many years working with the GYN oncology team in Manhattan at NYU. She just finished her NP degree. She lives in Brooklyn, wanted to come to Brooklyn and be part of our team providing care to our patients. Carol Lau is a RN. She speaks both Mandarin and Cantonese. She is an extremely valuable resource to our patients. She helps with all aspects of patient care. And again, we're very lucky to have her. And finally, our surgical coordinator. I specifically talk about her because patient satisfaction not always comes from how good is the doctor, but the ease of access, how friendly is the staff. Lila is an exceptional person. I mean, I have never seen an administrative person so dedicated. She sends us messages at 6, 7 p.m. Her job is to make sure patients are seen within a week. Any patient with a diagnosis of cancer, we have clear guidelines that they have to be seen within a week, even if we have to overbook our schedule. She works with the operating room, with the referring physicians, with any clearances that are needed to make sure none of our surgeries are delayed and the patient come to the day of their surgery ready to go. We are also multilingual. Between the physicians and the staff, there is at least one member that speaks one of these very common languages in Brooklyn. Obviously, we have our language services that we can use for other patients, but I think one of the previous speakers mentioned, it's very comforting for the patient when they have one of the staff, it doesn't have to be the physician necessarily, that speak their language, understand their culture, and can relieve a lot of their anxiety. Our presence is expanding in Brooklyn as well. we see Dr. Stasenko sees patients in Midwood and operates at Cobble Hill. Dr. Herman is already started seeing patients at Brooklyn Heights and in Bay Ridge at 67 and 4th. And myself and Dr. Diver, we see patients also at 67 and 4th. And we're hoping to have a presence also next to the hospital in the new building that's currently being built. What are the conditions we treat? We provide comprehensive management of all gynecologic cancers. We collaborate closely with our colleagues at the PCC for radiation treatment. All the gynecologic cancers are covered: ovary, uterus, cervix, external genitalia. Many of our surgeries are done minimally invasive, either robotic or laparoscopic, and even patients are surprised when we tell them we are going to do the staging procedure and you're likely going home the same day. Many of our patients are in their 70s or 80s, and initially they're very hesitant and they really feel they have to stay 2-3 days in the hospital, and they are surprised when 3-4 hours after the surgery they tell us they're ready to go home. But gynecologic cancer, also many of these patients present with advanced cancers and require a multidisciplinary approach. And we need to work with our colleagues, and we have an excellent collaboration with the surgical oncology team, Dr. Kaplan and his team, Dr. Shahebar and his team, and we reach out to the other specialties. The benefit is that no matter what specialty is needed, we have it available in Brooklyn, and we don't need to refer or send out our patients to Manhattan. We are one NYU GYN cancer team. So we have one tumor planning conference or tumor board that happens once a week with our colleagues from Manhattan and Long Island. So the patients have a treatment recommendation coming from a group of 30 to 40 physicians. And that's a plus. We're not isolated from the rest of the network. Our clinical trials, as I mentioned, we are in the process of building a clinical trials infrastructure in Brooklyn, and we are working closely with Dr. Pathori, who is the lead for clinical trials in Manhattan. She has built an exceptional network and clinical trials operations. She is the #1 enroller of patients in New York City and the #3 in the country. We also see a lot of patients with precancerous conditions. We get a lot of referrals of patients with abnormal pap smears, looking for conservative management. We provide HPV vaccination. We work closely with the genetics team for patients who have inherited predisposition, whether they're looking for prophylactic surgery, whether they just need to be monitored, and we refer them to our fertility preservation program with our colleagues from the reproductive endocrinology division. We also have a very good rapport with the Jehovah Witness community, and we have a bloodless surgery program, and we can accommodate these patients and offer them optimal outcomes. Finally, there's one more condition that we are part of as the GYN Oncology division. It's not a cancer condition, it's placenta accreta spectrum. This is a condition related to pregnancy that is associated with a high level of morbidity and even mortality. It's a surgically complex procedure. We have a multidisciplinary team that covers both Brooklyn and Manhattan. We have this program for now a year and a half with outcomes that are second to none in the country. And we collaborate. It's never a one-person effort. We collaborate closely with our colleagues from anesthesia, the maternal fetal medicine division, urology, critical care, and the NICU team. This is our contact. I'm happy to answer any questions. And if there's anything we can help with, our contact, and we can reach out to us easily. Thank you.
Good morning, everyone. My name is Dr. Justin Leventhal, one of the GU medical oncologist at Perlmutter Cancer Center in NYU Langone. Today, I'm going to be discussing precision medicine for advanced GU cancer. For those of you who may not be familiar with genitourinary oncology, I wanted to kind of highlight the tumor types that I specialize in. So this includes tumors of the kidney, ureter, bladder, prostate, urethra, and testes in both men and women. These are all of the GU medical oncologists actually at NYU across the network. I am the only one based here in Brooklyn, but despite that, I still give recommendations that are the consensus of our cumulative expertise throughout the network. We routinely meet to discuss difficult cases, new clinical data, as well as clinical trial data. So the treatment plan for our patients here in Brooklyn is really just as cutting edge, personalized, and comprehensive as if they were seen in Manhattan or on Long Island. This is a map of the different sites that I'm present in Brooklyn. So on Mondays, I'm in PCC Cobble Hill at 70 Atlantic, 1 day a week at PCC in Sunset Park. And then I do the rest of my week at PCC in Midwood. And I especially want to emphasize that our staff speaks 5 different languages across these different sites. So we're really able to take care of patients from all different cultural backgrounds and walks of life. Our approach for patients in their treatment plans is highly personalized on several different levels. This includes not only their characteristics as individuals, their medical history, different cultural preferences, but especially depends on the tumor and the characteristics of that. For the vast majority of our advanced cancer patients, we obtain next generation sequencing, both germline and somatic, to help us determine whether there's any targeted therapies that are required or perhaps a referral to one of the high-risk genetic centers is required. It also really helps inform patients and their families for what the diagnosis means for the patient as well as their loved ones. The field of precision theranostics is relatively new and has taken off in the past several years, particularly in prostate cancer. This has to do with using certain markers and scans to identify specific areas in the body for specific types of cancers, and then can deliver very focused methods of treatment to those areas. We routinely use the diagnostic proportion of this in Brooklyn currently, and for 2026, we'll have the therapeutic portion available as well. Finally, immunotherapy has been revolutionary for solid tumor malignancies over the past decade. This is especially true for kidney and bladder cancers as well. We routinely incorporate immunotherapy into our treatment plans for these patients. So one of my missions of coming to NYU was actually to increase the clinical trial availability for the patients that live here, and for those clinical trials to be available in the neighborhoods they live in. These are 4 studies that we have in the GU medical oncology disease space that are either currently open or pending activation within the next 2 months. I also want to highlight here that we have a phase 1 study. So phase 1 studies are the earliest phase studies and in general the most intensive studies, and are really the best way to get patients exposed to potentially life extending or life saving treatments that they can't otherwise have access to. And I'm really proud to say that we've been able to enroll the first patients in all of NYU and Brooklyn on this trial. And so that's been a special important part, and we continue to grow and to add to our clinical trial portfolio moving forward. This amazing treatment and highly personalized treatment that we give for patients quite literally takes a village, and I think that you've come to understand that today from my other colleagues that have presented. I work very closely with Dr. Daniels, who you heard from already in radiation oncology, and you'll hear from my colleague Dr. Pack in urologic oncology as a surgeon, but it's really so much more to take care of somebody with cancer and to take care of their family. We really champion a 360-degree outlook and treatment plan for these patients. So this includes making sure their diets are in line with our goals and having them meet with a nutritionist. Make sure that our patients can actually afford the treatments that we're recommending for them. So social worker, nurse navigators are super important for that. Also make sure that they can make it to their treatments and their different appointments. For patients who need sort of fertility or reproductive counseling and guidelines, we have Oncofertility. That's an amazing team. lots of our treatments can alter the sexual health of our patients. And for those of patients who still really want to maintain their sexual activity, we have lots of resources for them as well. And finally, supportive care and genetics are integral to our teams to make sure any other symptoms are taken care of, any distress that they may have with their diseases, and then to, of course, inform their patients and their family members moving forward. Thank you for your time this morning, and now I'll pass it off to my colleague, Dr. Pack.
Hey, hello, everyone. I'm Jamie Pack. I'm a urologic oncologist at NYU. I have the pleasure of working with Dr. Leventhal frequently. We correspond all the time. And I completed my urology residency at Columbia and did my 2-year fellowship in urologic oncology at NYU. Decided to stay here because I believe passionately about the NYU mission and serving our population here in Brooklyn. And I'm proud to say that over the past few years, we've consistently been ranked among the top urology programs. This year, we're number 2 in the country. So this is the team of urologic oncologists at NYU. I benefit immensely from the expertise of all my colleagues. We meet on a weekly basis to discuss more challenging cases. In addition to this team, all the medical oncologists, radiation oncologists, radiologists, and pathologists. So we do have a great collaboration with our team in Manhattan. Of these 7, I am the only urologist in this team that is in Brooklyn, and I'm 100% Brooklyn-based. So I see patients in our office in Brooklyn Heights, in Bay Ridge, and also our cancer center in Sunset Park. I operate both in our surgery center at Cobble Hill on 70 Atlantic Avenue and also in the hospital in Sunset Park. And these are the languages that are spoken by our staff in our various locations. So I want to give a sort of whirlwind tour of some of the advanced diagnostics and treatments that we offer. It's my personal passion to utilize these tools to offer the appropriate treatment that is personalized to not only the patient and their priorities, but also with an advanced and precise understanding of their cancer, of the aggressiveness of their cancer, and the extent, in order for us to provide effective treatment while minimizing the side effects. So I think this has been presented before, but we do have the Da Vinci robot at NYU Brooklyn, and my fellowship training was specialized in robotic surgery. So for kidney cancers, I would say greater than 95% of kidney cancers that I treat, I do perform robotic surgery. I perform both partial and radical nephrectomy. Partial nephrectomy is a surgical treatment of kidney masses where we only remove the mass and we preserve the normal kidney tissue on that side. The idea being that, especially in patients who have underlying kidney dysfunction, we try to preserve as much normal kidney tissue as possible. This is a more specialized surgery because the kidney is a very bloody organ. And so most urologists are not comfortable doing this, especially for larger kidney masses or masses that are more endophytic. But we do push the envelope in Brooklyn and NYU in general in offering this treatment. Part of what makes us more comfortable performing partial nephrectomies is the fact that we're able to do both intra and retroperitoneal partial nephrectomy, meaning depending on where the mass is located in the kidney, it's sometimes very difficult to do a partial nephrectomy, especially on the posterior side. So I've been trained in doing retropartial nephrectomies, meaning accessing the kidney from the back. This allows us to do partial nephrectomies for posterior masses, also minimizes any bowel side effects from surgery because we're not in the peritoneum where all the intestines are. For bladder cancer, for advanced diagnostics, we use something called blue light. This is a special chemical that we instill into a patient's bladder before we perform a resection of bladder tumors. This chemical binds to bladder cancer cells and allows us to more easily visualize bladder cancer in someone's bladder. It can be very difficult sometimes and very subtle, as you could see on the bottom left. It could be very patchy, it could blend in with the underlying bladder wall. And so This chemical with special cameras allow us to more easily spot and remove these cells. We offer bladder sparing trimodal therapy. These are, in patients who have more advanced local bladder cancer. The standard of care really is to remove the entire bladder, and in some patients that is an unacceptable way to live for them. And so we do offer treatments of chemotherapy with Dr. Leventhal and radiation therapy to the bladder. I do offer both robotic partial and radical cystectomy in appropriate patients, just removing the bladder that is involved with cancer while retaining the bladder in place can be appropriate. But in other patients, complete removal is offered and is the right way to go. More recently, we just recruited someone who trained at NYU and did 2 fellowships in reconstructive urology. So I work with them very closely to offer, once we remove the entire bladder, there are 3 ways to reconstruct your bladder. Most people get what's called an ileoconduit, where the urine drains to a bag on the skin, but we also offer more continent diversions, meaning ways that the urine doesn't just passively drain. So one is a neobladder. If you know Deion Sanders' story, he recently got one where it's connected to your urethra, so you're able to urinate as normal. This is an extremely difficult surgery, requires a lot of training, and it's not always appropriate for the right people. But we just did our first one as of last week. And so this is something that we're very comfortable doing. We also do a continent cutaneous reservoir to the skin called an Indiana pouch, where instead of wearing a bag, someone has a stoma on the skin. Whenever they need to urinate, they just catheterize the skin. So this is also a very good option that improves quality of life for people. So this is something that's very exciting and something new that we're doing. Lastly, prostate cancer. I do all my biopsies with something called software fusion. That's where we have our radiologist create a 3D model of every patient's prostate, also create a model of where the cancer is located. And when I do the biopsy, I use software to fuse the MRI images with our ultrasound images. This should be the only way a patient should get a prostate biopsy in 2025. It's been shown to increase the accuracy of prostate cancer and improve the detection of cancer. I also do this transperineally, which is not always offered by most people. This is a newer way to do prostate biopsies. If you're familiar with prostate biopsies, the traditional way was to do a transrectal, meaning the prostate needle goes through the rectal wall into the prostate. Even if you give someone appropriate antibiotics, they're at risk for a 1 to 5% risk of a severe infection that lands them in the hospital. So transperineal is where we use needles through the perineal skin between the scrotum and the rectum. This confers a risk of almost 0% infection. And so we don't even give antibiotics for this. So this is something that we're very excited to offer, both under local anesthesia and in the operating room. The last thing I want to talk about is something called focal therapy. This is something you might hear about a lot in the news. We offer both cryoablation and HIFU. Cryoablation is a freezing of cancer cells. HIFU is a high-intensity ultrasound that's focused. So I offer both, and we do what's called Focal One robotic focal HIFU. This is using a very new technology that allows us to be very precise in our treatment. And the overall idea is sort of similar to what happened with breast cancer, where in the past, wherever your cancer was, no matter how extensive it was, we did a radical mastectomy, removing the entire breast. But nowadays, we're much more precise based on an increased understanding of how extensive someone's cancer is. Now, we're doing the same thing in prostate. Because we use MRI, because we use fusion biopsy, we have a very good understanding of where your cancer is, how aggressive it is. If all your cancer is located in where your MRI is spotted, it makes you a very good candidate for something called focal therapy, meaning we only treat the areas of the prostate that have cancer, we leave the rest alone. The idea being that this can be as effective as radical treatments, such as removing the prostate entirely or giving radiation to the prostate while minimizing side effects. So you can see here sort of the rates that we've found in patients who get these sort of treatments. The risk of incontinence is close to 0 compared to higher rates with surgery or radiation. Also, the risk of erectile dysfunction is much lower than with surgery or radiation. So again, I'm pretty selective in who I offer this to, but whenever I see a patient who can have this, I'm always extremely excited to offer this because I do think the outcomes are very promising. We just did our 100th case of focal HIFU, which is the largest in this region. We offer this on 70 Atlantic Avenue. This is the device. It's very high-tech, very cool, and allows us to be extremely precise in how we visualize where we're going to give the treatment. And we can actually, in real time, track the effect of this treatment as we're doing it. So that's sort of a whirlwind tour of everything that we have to offer here in Brooklyn. Thank you for your time.
Hi, everybody. Good morning. I'm Dr. Neil Shelsky. Thanks for the opportunity to talk with you all and present some of the really exciting developments that we have in the Brain and Spine Tumor Center and our recent expansion in Brooklyn at Sunset Park. So we know that there's a large population of patients in Brooklyn that previously needed to travel for neuro-oncologic care. And the reason is because there were no local oncologists that specialize in these tumor types in Brooklyn and still not in Queens. So when Dr. Alex Miller at our tumor center here approached me about having a practice in Brooklyn and bringing neuro-oncology specialty to the area, that was really exciting. So I'll talk a little bit more about this and kind of our first time, developing this program here. So what do we have to offer here? So we have a number of different specialties that we can bring together. So I'm a neurologist with additional training in neuro-oncology and medical management of brain and spine tumors. And I work very closely with our neurosurgical colleagues, which you'll hear from in just a moment, after they have either biopsy or resection or other therapies in the OR, as well as with radiation oncology for local treatment to these tumors. We also have a fairly extensive team at Sunset Park. So we have an APP team to help with visits and calls and treatments, as well as we have our pharmacy, as well as investigational pharmacy for medications given on trial. And then we have a number of other supports, as you've heard about, with case management and oncology navigation, social work, and a community health worker. And these are all really important, pulling together to make sure that the burden of treatment and getting to visits and navigating this is not solely placed on the patient, but that we can help people get the treatment that they need. We also see patients in the hospital at the NYU Langone Brooklyn Hospital, which is just 2 blocks north of where I practice. So we also have a full neurology service there. We have an oncology consult service, neurointensive care, and neurology rehabilitation. And so often I may see a patient there before their diagnosis even comes back when we hear about that they have a new brain tumor. And then I can also go over to give additional consult recommendations or see patients in the hospital. So this is our main team here. So you'll hear from Drs. Rutledge and Andrewer about our neurosurgical program, and then Dr. Daniels from radiation oncology. So unfortunately, our surgeons weren't able to be here today, but they send a video here that I'm going to play. So hopefully the audio works okay.
Welcome, everybody. My name is Eric Ander. I'm the chief of the Division of Neurosurgery at NYU Langone Hospital, Brooklyn. It gives me great pleasure to be talking at this event. Wanted to give you a little sense of what we do in Brooklyn with regard to neurosurgical care. Just a little bit of background about myself. I was born in Japan, but raised in New York, and have been in Brooklyn for about the past 20 years. I was a Columbia undergrad in medical school and did my residency and infolded spine fellowship at NYU. And I've been with NYU pretty much since the merger. I've been in Brooklyn for the past 15 years, and the merger with NYU was in 2016 with the former Lutheran Medical Center, and I've had the position of chief of neurosurgery at our sort of hospital in Brooklyn for that entire time. I wanted to turn it over to my partner, Dr. Caleb Rutledge, to tell you a little bit about himself.
Hi, thanks so much for the opportunity to present today. I'm sorry that I could not be there in person this year, but it's really a privilege to be here. My name is Caleb Rutledge. I'm one of the neurosurgeons at NYU in Brooklyn. I joined the program in 2021. So I've been here for coming up on 4 years. I did my my neurosurgery training in San Francisco at UCSF, and then did subspecialty training in Phoenix at the Barrow Neurological Institute. I specialize or focus on cranial neurosurgery. I take care of vascular, cerebrovascular pathology, as well as brain tumors.
So, as you see, we're both subspecialty trained. Caleb in skull-based neurosurgery, myself in sort of complex spine surgery techniques. And so both of us have the capability of taking care of pretty much the gamut of anything in both cranial and spinal neurosurgery. We utilize the newest techniques. We have 24/7 in-house APP coverage, that's physician assistant coverage primarily, who are excellent, most of whom have been working with us more or less since the merger. So they're very experienced and know a lot about neurosurgery. We have incredible neuro ICU care. Our current neuro ICU director, our current actually chief of neurology, was the neuro ICU director in Manhattan. And we take a lot of pride in the way in which we coordinate follow-up. We do that very closely with our office, but also with our colleagues, many of whom are speaking today. And of course, being as a part of a large, a world-class medical center, we have access to pretty much all the same clinical trials that are on offer pretty much throughout the system. So this is something that we're proud to offer as part of our care for neurosurgical oncology patients. Since we've been here in 2016, we've, I guess, quintupled the number of cases we've done in Brooklyn. Brooklyn used to be covered by a private group, and now we have, a dedicated 24/7 group that basically covers all neurosurgical care. But in that time, that really hasn't, really had any sort of negative impact on metrics with respect to quality. We've decreased the length of stay for a lot of our patients. We've decreased mortality rates amongst our patients on the neurosurgery service, and actually increased the complexity of cases. Oftentimes you don't see those things moving in tandem. And I think that's really a testament to the level of care that we have with the facility, with our, access to equipment and, the latest techniques, but really it's a testament to the quality of the people that we have here. And the goal here is obviously to never have anybody have to travel outside the borough for any subspecialty care where neurosurgery is concerned. So this is just a graph showing sort of hospital-acquired conditions, infection rates and such, that the hospital in general has really been able to decrease. And again, this is sort of a graphical representation of the fact that even though we've increased the complexity of cases that we offer and the number of services we offer, we really haven't. In fact, we've decreased, the number of complications and increased the level of safety for our patients, and through a lot of these harm prevention measures that you see on the left. So with respect to spine tumor, the surgery, we sort of do everything. We have all the bells and whistles that they have across the river. We have a Globus robot system that we use, which basically allows us to sort of, with pinpoint precision, navigate our screw placement. A lot of patients with oncologic problems in the spine come in with instability because the tumor is sort of eaten away at the sort of the bony integrity. And so we can basically plan out these surgeries preoperatively, know exactly what kind of surgical sort of decompression we need, and place screws with incredible accuracy. We also have implants that are specifically designed for oncologic surgery. So you can see on the right there, we can use these implants, which will allow patients to sort of get radiation afterwards and such without necessarily having the interference from the typical hardware. And we have an incredibly good neurophysiological monitoring program, which allows us to do these surgeries very, very safely, gives us real-time feedback in the operating room about what's going on. So as far as spine surgery goes, we run the gamut. There's basically nothing we can't take care of in Brooklyn. And then I'm going to let Dr. Rutledge talk about the cranial side.
Really want to echo what Eric has said already. As far as cranial neurosurgical oncology goes in Brooklyn, we really do the full spectrum of it. We take care of primary brain tumors, brain tumor metastases. We take care of benign brain tumors, including meningioma, pituitary adenomas, as well as head and neck tumors. We take care of the big cases, the complex cases. You can see these are just some representative examples of MRI scans from patients that I've taken care of here in Brooklyn. Just like Eric mentioned, for the spine part of our program, we really have access to all the tools, all the equipment that we have across the river. We have a brand new state-of-the-art hybrid operating room in Brooklyn with biplane fluoroscopy. So I can do a preoperative tumor embolization followed by a surgical resection. We have brain lab neuronavigation so that we can plan craniotomies and openings tailored to each individual patient and tumor, the microscope, intraoperative ultrasound. We also, as Eric mentioned, have a great neurophysiologic team to do intraoperative monitoring. So we can do motor mapping for, say, a brain tumor or metastasis that's in an eloquent part of the brain to maximize extent of resection and do the surgery as safely as possible. Eric also mentioned we have a really excellent neurocritical care team, 24/7 coverage of fellowship-trained neurointensivists who help us take really excellent care of our patients, both in the preoperative and postoperative setting. And then the final thing I want to mention, just since I've been here in 2021, our whole the program has grown tremendously. We have a neuro-oncologist who you're hearing from, a dedicated neuro-oncologist in Brooklyn now that you're hearing from later today. We have a great team from ENT, Lindsay Moses, who does head and neck tumors, and we frequently collaborate on cases, and recently have added a skull base otolaryngologist who is really going to expand our ability to do more skull-based tumors and transsphenoidal approaches. So, in short, we do it all in Brooklyn. We do the full gamut of cranial neurosurgery, and we do it very well. These are the locations that Dr. Ander and I see patients. So we see patients every week, a couple days a week in Brooklyn. We're located at the Brooklyn Medical Pavilion, where we see patients on Tuesdays, and then we also see patients at the Cobble Hill location on Wednesdays and Thursdays. Our team actually speaks quite a few languages: Cantonese, Taishanese, Mandarin, Russian also, yes. So we cover a lot of bases in that regard. We take a tremendous amount of pride in taking care of the patients and the patient populations in our community.
Our goal is basically to keep people in the community with their families, with their support networks. I think that what we've shown you basically demonstrates that we run the full gamut. Any questions that you have, we aren't there in person to answer, but feel free to route. I'm sure they're going to show contact information for us, and I'll be very happy to hear from any or all of you at some point. So thank you again for the opportunity. Welcome, everybody.
Nope. All right, so you heard from them about how our patients have access to the latest surgical techniques and expertise, and really sets them up on a great first step often in our patients' journeys. So like they mentioned, I see patients at Sunset Park at the cancer center there, which is a fantastic situation set up for us, and that we also have infusion and radiation in the same building there. You'll hear about today about the high rankings of a number of things about NYU in the system, but a couple that are really meaningful to our patients in neuro-oncology are highlighted here. So one of them being that NYU as a system is ranked #1 in the country for neurology and neurosurgery, as well as the highest ranking for safety in the hospital. So these are two really important things that our patients see. Other things, of course, the cancer center is very highly ranked, and also rehabilitation. So often our patients will have either brain or spine related injuries from their disease, and treatments as well as coping mechanisms to try to have them be as functional as possible helps improve their quality of life and performance. Mentioned a little bit about quality otherwise. So what do we see in neuro-oncology? So some of these were mentioned. So we see high and low grade brain tumors. So the most common in adults is glioblastoma, as well as IDH mutant gliomas, which there has been a lot of development in treatments recently. We also see meningiomas, which are often benign brain tumors, and we see lymphoma in the brain or spinal cord as well. We're also very happy to collaborate with our medical oncologists for metastases to the brain or the leptomeninges in co-management of these patients, as well as in my capacity as a neurologist specializing in cancer and cancer care. I also see patients for complications of their cancers or from their treatments as they're receiving newer and newer treatments. So frequently in the hospital, we'll see patients for immune effector cell neurotoxicity or other perineoplastic syndromes. So patients have a great multidisciplinary team taking care of them, but also our current treatment is never good enough. So there's a big focus here on clinical trial expansion. So this is our some of our clinical trials that are currently open in Manhattan. Since starting here recently, we're actually ahead of schedule for some of these. So the ones in blue are currently opening at Brooklyn, and the one in purple is already open. So we really have an excellent research infrastructure here and a real push to give our patients as promising new treatments as we can offer them, and not have to have them travel far from home. All right, so thanks for your time, and this is information how to contact us. Thank you.
Thank you, Dr. Shelsky, and I'm going to talk to you about hematology. So it's not brain surgery. I just came up with it. I wanted to make sure. All right, so where are we located? We're fortunate to be located all across the borough, including our 4th Avenue Oncology there. But basically, our main vision and what we abide by is to make it as easy as possible to see patients. And we really see them within a week, almost always, unless they request a later appointment. And we maintain the same quality across the network. That the third point is really the main one, that we really want to expand services. So to some things that have never been offered in Brooklyn in history. And I'll talk about this, and obviously excellence in patient care. These are some of the folks who are coming. I want to point out Dr. Peter Martin, who's joining us from Cornell, where he's serving as the chief of lymphoma for another 2 weeks. Before coming to us, he's going to be seeing patients at the PCC Sunset Park. Dr. Amy Sun, that we recruited from UCLA. You met Dr. Sokolov before. And we have some general hematologist oncologists who with an interest in classical hematology. We also partner with our family health center where Dr. Balmiki sees patients, and many of them from classical hematology. I just want to show you that bringing expertise to NYU Brooklyn has really made a big difference. You can see on the left-hand side how much we've grown our volume, and overall it's almost 50% of the past 3 years. In hematology on the top right, in particular, you can see we grew the volume by 134%, and that both in cancer and classical hematology, as you can see. And why are we growing so much? Because when patients come to us, they like it. We talked about patient experience, but it's been a great focus of ours. Our target is to really achieve above 97% patient satisfaction rate, and we're just about there. The last quarter, we've had 100% satisfaction at Cobble Hill, and I know some people in the audience telling me that they've had family, friends, or community members who had the care received there, and they share the same feeling, but we're at 98 or 97% across the board. So we're doing great from that perspective. So we treat lymphoma, leukemia, myeloma. We offer a bunch of clinical trials across these diseases, but the exciting thing that's really coming is the transplant and cell therapy. On the top right, you see that the new building is going to be the new ambulatory hub, which is going to house ambulatory surgery, but also there's going to be the 5th floor dedicated to our transplant, cell therapy, and hematology patients. We'll also have breast imaging there. And at the same time, at our main hospital, we'll have a brand new unit, a bone marrow transplant cell therapy dedicated unit that will serve our patients on the inpatient side. And it will be a fully integrated inpatient, outpatient coordination. Why is it important for us and why is it important for NYU to open it? Is because we're simply the best in bone marrow transplant in the tri-state area. I've listed every single program recognized by FACT and the CIBMTR. That's 2024 because we're not done yet with 2025, but we've been at the top across the board. If there's any institution that you guys might know of that's not listed there, it's because they're simply either not accredited or on probation or something else. I'm not hiding any data. They cannot publish their data, but we're the best and we're bringing the best to Brooklyn. So some about the T-cell engaging therapies that, we've had people come from all over to see us for this. And it's, I've put this slide with the Jim Carrey movie where, he asks the waitress, what's the soup du jour? She responds, it's the soup of the day. He's like, that sounds good. I'll have one of those. And so we've had patients come to us for CAR T-cell therapy without really understanding what that entails, but it's really cool. So you take the patient's T-cells, they want some of your immune cells, we re-engineer them in the lab so that they can now recognize the cancer cell. They're going to have a receptor on the surface that will recognize the cancer cell and wipe them out. The bispecific T-cell engagers are also pretty cool, where you give a drug that will bind that same T-cell and bind the cancer drug and send a signal for the T-cell to go ahead and get rid of the cancer cell. Tumor infiltrating lymphocytes are also pretty cool, but I don't specialize in that, so I'm not going to talk much about it. But why do I bring these up? So CAR T cells are really innovative. It's created a lot of interest, but at NYU, not only are we part of this, but we're leading big trials in this. And right in the heart of Brooklyn, I don't want to self-promote, but this is one of the trials, a multi-center study called Imagine-3 for myeloma patients, where a novel construct of a CAR T cell called anito-cell is being compared to the standard of care. It's a phase 3 study that we're leading here from Brooklyn, and we were the first site worldwide to open it, and we're leading globally. If you see at the bottom right, there's 91 sites across the globe. And if you look at the team's #1 top enrolling site, it's us here at NYU. So I've had patients, literally, I can tell you, a well-connected attorney from Chicago who traveled to come and see me. But, and it's great, I'll take care of any patient, but we have it here in your backyard. And people just need to know that they can have access to all of these trials and innovative therapies right here in Brooklyn. And I wouldn't have come to NYU if it was just to cater to the people who will travel to come and see us. I really want the New York City and Brooklyn community to know that we're really providing top of the line therapies. There was another slide that is missing here, but I want to tell you, we're also, for the bispecific T-cell engagers, we have this investigator-initiated study that we're leading right here in Brooklyn. All these therapies have toxicities where patients can get pretty sick because our body senses our immune system going haywire to try and blast those cancer cells, but it's interpreting it as like, oh, maybe I have a systemic infection, and it could virtually mimic sepsis. And so that made it impossible to apply these kind of therapies in more rural areas or people who don't have easy access to an academic hospital. So we're coming up with an innovative way to try and prevent these from happening and administer all these therapies as outpatient. It's a study that is investigator initiated right from us here in Brooklyn. And we are holding the IND, which is something that's given for novel drug therapy with the FDA. And we're about to launch that system-wide very soon. And that's about it. So our goal is really, while we're spread across the borough for our cancer centers to provide high, world-class level of care, we have our academic hub in Sunset Park where we bring the next level type of cutting-edge therapies. And that's about it. Thank you. Next will be, you'll hear from our radiation oncology colleague, Dr. Tom Daniels, who are Chief of Radiation Oncology here in Sunset Park. Please welcome.
But I want to talk to you about radiation oncology. I'm Thomas Daniels. I'm the Associate Medical Director for Brooklyn and Manhattan, and I'm the Section Chief in Brooklyn and Sunset Park. Our center is located here in 57 18 Second Avenue. Due to the nature of having large pieces of equipment, we have really, at this point, one base in Brooklyn. As far as the languages spoken by the staff, this is what we came up with: American Sign Language, in addition to a number of the other languages that have a high concentration of native speakers in the borough. This is what the outside of the building looks like. So we are on the ground floor here, and then and we share this with ENT. There's a PET scanner and 2 machines here, and on the second floor is where medical oncology is. To give you some frame of reference, this is the main hospital right here. And then also, very importantly for our patients, not the Dunkin' Donuts here, but right here we have valet parking where patients can come and they'll can park for free for those who drive. So when you think about sort of the standard way that radiation has been given, the first thing is you go meet the doctor, then they make an appointment for a simulation that can take a couple hours. That's just a CT scan. They say, well, I just had a CT scan yesterday. We know, but you have to have another one for radiation. Then over the course of many days, a week, depending on the complexity of the plan, some people are involved in their care who the patients never meet, but they are essentially computer programmers. There's quality assurance. And then the radiation treatments can take anywhere from 15 minutes to 30 minutes. When I started doing this 20 years ago, prostate treatments took 9 weeks. Now, a lot of them can be done in 5 days. Then after that, there's patient follow-up. So our current team, I'm trained at Mayo Clinic, Dr. Colin Hill, who is head, neck, and GI. He's at Hopkins, Dr. Mahadavan, Harvard, and then we've got 2 local products, Dr. Colangelo and Abelos, who are doing GU and breast. So that's the consultation part. And then for the treatment planning, we have to do the CT scan. Now, currently, our CT scanner does double duty as a PET CT scanner. It's an identical machine, but there's some settings that need to be changed to do the radiation treatment planning portion. But now we're combining the two so that for patients that we know need a PET scan, we can do a CT scan at the same time. So they took a flat tabletop. So that first part was part of the diagnosis part. For certain disease sites where we know they're going to need a PET scan and we know they're going to need a CT scan, we can combine them in one. This is one of the machines, the linear accelerator, and we put them in the same position as the simulation. The radiation comes out of here. There are imaging panels that can pop out of the machine to get different types of either kilovoltage imaging or cone beam CT scans for alignment. And this is a video that I'm going to play. Okay, so I want to talk you through this. I don't want to make this a history lesson, but to understand, what you see here is that pink thing in the middle is the tumor that we want to treat, and those other 2 areas are kidneys that we don't want to treat. So as the machine is rotating around the patient, you can see in the lower left-hand corner of the screen, those leaves are moving in and out. So that takes a lot of, programming. How do I get to the next? There we go. So that's quite a bit different than was done many years ago. So a lot of technology has come along like in any other field. But what we used to do when we do radiation, we'd have a guy who would cut a block and they'd make an aperture where the radiation would come out. But now that's mounted in the machine head. And this is the physical part. So it's a little easier to understand than the computer part, which is also grown at probably a faster rate. But now that same that same thing is done within the machine. So a radiation treatment such as whole brain radiation, which is something that we still do occasionally, we can now make those blocks here on the machine, but we don't really necessarily want to do that because radiation has become more focal, just as the other specialties have talked about, how we don't want to treat the whole organ. We only want to treat certain parts. So this is what we look like after several days of radiation planning, where the whole brain is getting radiation, a lot of toxicity. You're treating a lot of brain that probably doesn't have any tumor in it. But now we're able to do something, we're sort of like spot welding the tumors. And this is essentially a heat map of the radiation doses in a patient who's got 6 or 7 metastases. So this is 1 day, the last one was 10 days. So we're doing it shorter, faster, more focal, and with fewer toxicities. The big thing that we've added, and to stress that NYU has made a significant commitment to bring the best technology and the best physicians to the borough, is now we're offering something called adaptive planning. So all the steps that we'd shown before, where you have to come in, get a scan, have a plan, we're all sort of doing it in real time now. So now you do a consultation, we do generate a plan in advance, but we're able to do a cone beam CT scan and then take a look at that and essentially on the fly make modifications so the organs that might be closer than they were on the initial scan are now accounted for, and we're basically able to generate a new plan with the same steps, quality assurance and all that, in just a matter of minutes. And all this, once again, 5 days, not 45 days. And this is, of course, the machine. It integrates artificial intelligence, but this is the Ethos machine, which we've had now for under a year, and this is the machine that we use for this adaptive planning. This is the list of clinical trials that we have open for radiation specific, for breast, for omission of radiation patients, for prostate cancer, brain and spinal, Dr. Shielski mentioned. And finally, I do want to stress that something you've heard over and over today is that we put a lot of effort into making sure that all the patients' appointments are coordinated. We routinely will work together with the schedulers, for instance, in medical oncology, to get patients in from the same day. I received a nice comment from that earlier on. But also, we're also open to having patients who are seen, for instance, upstairs by, for instance, Dr. Sokoloff, and says that we need to see a radiation oncologist today. We're more than happy to see them the same day. And that's the referral page, and I think that's it for me. Okay. Thanks.
Hi, everyone. I'm Gabrielle Gargano. Thank you all so much for being here today. I'm the program manager for the Clinical Trials Office in Sunset Park, or CTO as I'll be referring to it. And I'll be presenting alongside Dr. Giabrio on the vital role of cancer trials in Sunset Park. And I just want to thank everybody for including their clinical trials in their presentation. I really appreciated that. But for a bit of background, one of the larger issues we face on a broader scale in cancer research is a low rate of participation in oncology trials. So less than 5% of adult cancer patients actually enroll into a trial, even though 70% of Americans are inclined or very willing to participate. Patients from minoritized racial and ethnic backgrounds are consistently underrepresented as a result of this low enrollment. And insufficient patient enrollment to clinical trials is both a serious and costly problem and is often considered the most critical barrier to their timely execution. So higher rates of enrollment, fair representation, and timely completion of clinical trials allows us to advance these treatments faster and ensure that they are reaching the intended population. Additionally, the disparity we see in interest versus actual participation tells us that this low rate of enrollment is not entirely due to patient attitudes towards research, but is also related to clinical and structural barriers as well, such as stringent eligibility criteria, physician reluctance to participate in research, and of course, a lack of availability to clinical trials in your area. And one of the ways NYU is addressing these barriers is, as you've probably gathered, expanding access across the boroughs, which leads me to our expansion into Sunset Park. So why did we decide to choose Sunset Park? As you know, NYU has a lot of different locations we could have used for our expansion, but as you've also probably gathered, Brooklyn is an important part of the larger catchment area for NYU, as it is the most populated borough and a relatively diverse borough as well, with Sunset Park specifically having some of the highest concentrations of Hispanic and Asian communities in Brooklyn. Additionally, there was a surge of patient cases in Sunset Park from 2021 to 2023, as well as an increased amount of trial referrals, meaning that there's been an increase in the amount of patients from Brooklyn being referred to Manhattan specifically for treatment on a clinical trial. So a combination of these factors led to hospital and PCC leadership recognizing this pressing demand for trial access in Brooklyn. And through exceptional collaboration, we have really just seen exponential growth of the Brooklyn program only within the past 2 years. And so our goal here is to establish a satellite clinical trials office in Brooklyn to augment comprehensive trial enrollment. And this will also allow us to better alleviate socioeconomic barriers and help mitigate disparities in health outcomes, as well as, of course, provide access to early and advanced phase trials and our own investigator-initiated trials right here in Brooklyn, so our patients don't have to leave the borough to access top quality care. And part of what sets PCC apart in our expansion is the fact that we utilize a centralized infrastructure. So all of the teams you see on the right-hand side, so our data team, business unit, protocol development, these are our non-patient facing teams, and they support our Manhattan, Long Island, and Brooklyn campuses all in trial activity. We, of course, have to have our clinic and laboratory staff on site at each campus, as those roles are patient-facing and have on-site responsibilities. But whether you are in a more centralized role or on-site at a specific campus, all groups report up to the same PCC leadership. So specifically, our Senior Director of the Clinical Trials Office, Ankita Joshi, who is here today, and Dr. Janice Menard, who is our Associate Director of Clinical Research for the Perlmutter Cancer Center. And utilizing a centralized model allows for greater cohesion across all sites, better access for our patients, and also improved PI oversight across our campuses since we all function under one NYU umbrella. But of course, the focus for today is Brooklyn, so I'll also be talking about the Brooklyn-specific infrastructure and trial activity before handing it over to Dr. Diabrio. So, of course, this is the team in Brooklyn, and you've all met Dr. Diabrio and Dr. LaHood at this point. But in addition to all of the amazing work they do in just the disease space, they also serve as our lead investigators for our breast and hematology oncology trials, respectively. We have myself as the program manager, and I would be remiss if I didn't give our staff a shout out. So we have our two wonderful coordinators, Anna and Mari, and our research nurse practitioner, Stephanie, who has been a wonderful addition to our team. And so to take a look at our clinical trials snapshot of our activity, this is as of October 31st, but I do just want to pause here for a minute and just emphasize the fact that we've been able to accomplish all of this in just the past 2 years. Prior to the end of 2023, there was essentially no clinical trial infrastructure in Brooklyn. So since then, we've gone from 0 to 4 full-time employees, soon to be 5 actually. And we'll now have CTO staff on site at 2 campuses, which I'll show you on the next slide. And just in this past year, we've been able to establish a fully functional investigational pharmacy for the clinical trials office and the Brooklyn Hospital. And we've also been able to establish a CTO dedicated research biospecimen processing lab. And in terms of our accruals, as of October 31st in 2025 alone, we've had 19 therapeutic accruals, which is a 137% increase from 2024. And we also have 21 therapeutic protocols that are actively enrolling, which is a 62% increase from 2024. But in addition to those 21, we are expanding and opening another 14, which will allow us to reach 8 disease management groups across the Sunset Park and Brooklyn network. And lastly, just to highlight our 2 locations, so I kind of zoomed in on them here in the lower right-hand corner, but of course the Sunset Park campus is where the clinical trials office is located, and it's where all of our patients will be treated. And we also have our ambulatory care Bay Ridge location, where our CTO staff will be on site to assist with non-treatment study-related tasks for our GYN trials. And so with that, I will hand it over to Dr. Diabrio, who will discuss what our clinical experience has been like since expanding into these areas.
Thank you so much. And as Gabby mentioned, it's really an honor and a privilege to be part of this slide set because we take great pride in all of the things we've done and couldn't have done it without the support of many people in this room. And so we're really excited to share this with you. So really, as Gabby mentioned, we want to serve our community. But in order to do that, we have to be really smart As you know, resources come based on need, and we had to select trials specifically for Brooklyn. As you've heard from every single person in this room today, everybody wants to participate in trials, but we also want to bring trials to the communities that need them the most. And so we used a metric-based trial selection to ensure that we were matching our Brooklyn patients to the populations we were seeing in the clinic. From 2023 onwards, you've seen a huge onrush of new providers coming into Brooklyn. We've all learned our practices have changed. I can tell you this is very different from the demographic I was seeing somewhere else in the NYU system in Long Island, but it was important for us to recognize what that patient population was. And we used those metrics, thanks to our wonderful data team, to assess what trials to prioritize. So there's a large number of, say, for example, pancreatic cancer, CRC, colorectal patients that we can find in our data reports. And so we're going to be opening a phase 1 basket trial, for example, looking for patients in these cohorts. We also want to open some non-therapeutic trials that match our communities. We have 2 of them, for example. One is in collaboration with Georgetown University, led by Dr. Marianne Kwa, one of our breast oncologists in Manhattan, that's comparing breast cancer survivorship and quality of life between non-Hispanic white women and Chinese or Taiwanese American women. Sunset Park is one of the largest Chinatowns, Chinese communities. So this was a really opportune study to bring to us. I also will highlight the triple negative trial in a few slides coming up. That is something that I'm personally incredibly proud of, and I know our group is as well. So triple negative breast cancer accounts for about 10 to 17% of all breast cancers, but it's approximately 25,000 to 30,000 cases in the US, but there's a disproportionate number of cancer-related deaths from this disease. And we do know that these women tend to be younger at diagnosis, often of African-American, Hispanic descent, and also associated with the BRCA gene, also seen in some of our communities, especially in our Jewish communities, and also present with high-grade disease and visceral mets. So really, the microcosm that is Brooklyn has all of these communities, and we really wanted to bring this trial here. So this is the SCARLET study. The investigator, the lead investigator is Dr. Priyanka Sharma from University of Kansas. This is a cooperative group study, and it's really looking at comparing the standard of care, which is 4 different chemotherapies in addition to immunotherapy for triple negative cancer, compared to what we call a de-escalated regimen of 2 chemotherapies with immunotherapy. So really trying to achieve the same outcomes with less toxic treatment. So what happened in Brooklyn? So the SCARLET study is open across the network. And if you look at the accruals across the network, as you can see, across all 3 sites, we've got 17 accruals. I want you to sort of pay attention to the pie chart there. What happened without Brooklyn? And then here's what happened when we added in Brooklyn. As you can see, we had a dramatic improvement in the enrollment of patients who actually represented the community where we see these patients. So we were happy to show that there was proof of principle. We bought a trial that really spoke to the community. There was appetite for these patients to be enrolled. Here's where I also want to thank our community health workers, our navigation team, because without education of the community at large, we would not be able to accrue these patients. As you can imagine, trying to consent somebody in a different language can be harder. And this is where we really look to our community health, our staff who speak multiple languages to help out as well. So this, again, for us was a huge success in our principle. We have several open trials. This is our roster. Gabby every month sends out a list of new studies that we're opening. But I want to highlight the phase 1 trial that Dr. Liebenthal mentioned, one of our first phase 1 trials in Brooklyn, and also the first patient enrolled in this study throughout the network on a phase 1 study. So extremely happy to. As you can see, breast is a little overrepresented thanks to yours truly, but that's going to change as we go along, and we now have 8 disease management groups represented. So the hematological malignancies, thanks to my colleague, Dr. Lahoud, also coming a long way, one of the highest accruers in the cell therapy trials. And we also have the non-therapeutic space growing. I'm going to highlight the study that he's highlighted where NYU has one of the highest accruals in the country. And he happens to be the global PI. Future directions, we want to increase trial complexity. Clearly, treatments are complex, diseases are complex. We want to offer all phases of clinical trials, not just the phase 3 studies, but also access to early phase drugs that are only available on study. To borrow a phrase from Dr. Paturi, clinical trials do save lives, and we really want to focus on bringing that to our community. So we're going to incorporate phase 1 trials, and we're working on infrastructure to do that, not just in GU, but also trials across the spectrum. Importantly, in red there, we are bringing 2 glioblastoma trials to Brooklyn, thanks to Neil Shulsky and our Neuro-Oncology group now. This will be the first of their kind, one for newly diagnosed GBM patients and one for recurrent. And thanks to our radiation oncology group, we have the capacity to do that. We're also shifting towards industry-sponsored studies for our industry partners who are here today. Brooklyn has all the bells and whistles that you could expect in Manhattan and Long Island. And so we welcome opening these studies. We're able to provide full oversight and completely standard study conduct because of our centralized infrastructure. And so there should be no hesitation in opening Brooklyn as a satellite site of the main campus. Last but not the least, in investigator-initiated trials, Dr. Lahoud is the lead one on, taking the lead on that. He's developed a concept that he spoke about, though we didn't see the slide, and is the national lead. He's working with one of our residents in the hospital to develop this program. It will be opening across the country. We're also expanding to our GYN oncology, knowing that we have a small footprint. We're trying to expand access to where our GYN oncologists practice, and a first pragmatic trial will be opening there soon. And finally, with the opening of the new oncology ward, the hematology ward in 2027, we're looking to open up more complex hematology trials also in the inpatient space. With that, I will end and leave it to our forward-looking slides next. Okay.
All right, it's really great to be here. And I think this part of the program is really intended to be and will be in a few minutes more of a discussion and really getting input from the group and all of you and your perspective as to where we go from here. I'm John Leonard. I joined NYU back in June. I'm the Division Director of Hematology Medical Oncology. I'm also the Director for the Center for Blood Cancers and the Interim Director of the Perlmutter Cancer Center. I'll let Casey introduce herself.
Sure. Hi, everyone. My name is Casey Bond. I am the Executive Director for Administration for the Perlmutter Cancer Center. I've been here just over 10 years, all of those at PCC, first working in Division of Hematology and Medical Oncology, and various hats have been worn since then. And I think you should have not told everybody that you just got here, because I bet they wouldn't have known based on what you're about to say.
Well, I can't take credit for much of anything, which I have to be honest about. But I will say that I came to NYU for a couple of different reasons. And I think what the program has shown today, I think exemplifies all of that. I really wanted to be at an institution where things were on the rise, where we were having an impact and where there was more and more happening every day, and a great opportunity to do more, to not just tread water, to not just kind of keep our heads above water or try to keep our heads above water, but to really continue to make an impact. I also really loved the people that I met at NYU, and that has really has grown every day. And I think we've seen wonderful examples of the people here and the impact that they're having and the great collaborators they are and the care that they have for the mission that we have. And then finally, another big aspect is for me was to be able to impact the city, to impact Brooklyn, to impact Long Island, and other areas in the region. And I think there's no center, no cancer center certainly, but I think no health system that is doing that in a better way, that is more attentive to the missions of providing great care as well as education and research. And we've seen great examples of that. So, I'm really thrilled to be here. And I think that the excitement, it's not all about me, obviously, but is really what we've heard today. And I think the fact that you all are here dedicating your time and your work to either learn about this or to contribute to this is really important and special. So we just have a couple of slides. And I think, at this point, it kind of goes without saying after all we've talked about today. I wanted, and I think my personal mission, and I think all of us want to be at a place where our family member, our loved one, our friend can get great care. They don't have to go anywhere else, and they get the same great care no matter where they're accessing our programs. And certainly, I think we can say in Brooklyn, there is no doubt about that from what we've heard today and what we know and what we're committed to, and that the patient outcomes and patient experience need to be first rate, that we are linked to our research programs. Oncology in particular is really evolving on a day-to-day, week-to-week, month-to-month basis with every meeting, every paper published, every new genetic test, every new drug, every new diagnostic procedure, every new surgical technique or radiation oncology advancement. And all of those are linked to research programs that stem from the bench to the bedside to the community. And we need to really have, and we do have all of those in one place. And that we want to just not just provide state-of-the-art care, but actually contribute to making care better and making it better for everyone, not just people that can find their way to a referral center. And I think we've, again, seen great examples of all of that today. This one mine too. Same, I love this tagline. Everyone has seen this on TV and otherwise. And I think, if you want to provide care to large numbers of patients, it's a health system and it's linking of all the components of the health system together. And I've been amazed. I mean, in my first month at NYU, one of my patients happened to live on Long Island and happened to see me in Manhattan, but wanted to get their treatment on Long Island. And it could have been Brooklyn. It has been Brooklyn also. And it took me 2 extra minutes to arrange that care close to their home, and it was convenient for them, and which is how it should be, not for my convenience or the health system's convenience. And so being integrated, providing the trials that you just heard about, letting patients have access easily and in a timely fashion, especially in cancer. Time is everything. We know that patients who wait a long time to get treatment for whatever reason, often not their own choosing, they do less well. And so being able to get patients in and if you can't access care, you're not getting quality care. And so the first step of providing quality care is getting people in and getting them a plan, putting them at ease, and getting them on their way to a recovery. And obviously this links to a footprint that goes beyond Manhattan, goes into Brooklyn, goes into Queens, is going to Staten Island soon, is going to Nassau and Suffolk. And so I think it really, the number of people that we're able to serve is really exceptional. So I'll let you take the next few.
Sure. So I think, just to build on that concept and a lot of what you heard today about our mission really being to bring the care to the patient. This system has grown a ton in the 10 years that I've been here. We went from having 1 hospital to having 4 hospitals. We have added countless outpatient sites. For PCC right now, we have 11 sites in total, soon to be 12. And I think, what's interesting about this is that NYU Langone's mission early on was really just to expand the footprint, to be able to open practices across this network and, generally speaking, give patients care. That mission sort of evolved from just having a large enough footprint to really integrating that system, which is what we really hoped to demonstrate to all of you today, is that it's not as simple as having a brick and mortar where there are doctors and nurses and secretaries to look after your patients. It's that the services that are provided at all of these locations are truly integrated, not just across the specialists of the physicians that you heard from today, but with our clinical trials office, but with our navigation programs, with which our financial counseling services and other services that we think are important to provide to our patients as a health system. And so, you heard a lot today about some of the examples on this slide specific to Brooklyn. So having a PET CT in Brooklyn is important. It's hard for our patients to travel. They don't feel well. They have jobs and children and all the things that we're all responsible for, and they have a cancer diagnosis. So opening services like the PET CT, like the transplant unit that Dr. Lahoud spoke of that's going to be opened in the hospital. So we sort of went from let's have a large footprint to let's provide integrated care. And now the future is really providing truly specialized things, phase 1 trials, transplant opportunities. You heard a lot about them today. many of those services are not available in community settings in many places in the country and certainly across the world. And so I think that's really the focus of where we want to go. And you heard, a lot today, and I hope it came across that it's not good enough for us just to provide the service. It has to be a quality service, and it has to be a service that really improves outcomes for our patients. So I'm going to play a video. This is Dr. Il-Sung Cho, who's the Chief Quality Officer for NYU Langone, and then I'll speak a little bit about it afterwards. Oh no, maybe we won't play it. Okay, I'm gonna do my best Il-Sung Cho impression. So essentially what he talks about in this video is that I'm sure many of you know there are many ratings, right, that hospitals are given. There's US News and World Report, which we talked about today. There's something called Leapfrog for safety. One of those ratings is Vizient. And Vizient is really focused on quality outcomes for patients. And I think it is amongst the most meaningful because it looks at things like survival. It looks like things like readmission rates, hospital-acquired infections, things that are true clinical outcomes for our patients. And we're proud to say that NYU Langone has been ranked #1 by Vizient for the last 3 years in a row. We are the only health system ever in the history of the rankings to achieve that. And it's something that we're extremely proud of. And I think that it very much lives at the core of everything that we do, that it's not sufficient just to provide the service, but we need to provide the service in a quality way. And connected to that is that it's not just good enough to have the service and have a quality service, but we also need to have an experience that ultimately leaves our patients feeling cared for and heard and understood. I think, probably every single one of us in this room has had our own experience or an experience with a loved one, and we understand how hard it can be. And I think part of what we are really passionate about doing is caring for the whole person and not just for the diagnosis, and not making people feel, like they're nothing more than their tumor. And so you got to hear today from Megan and Tori about the amazing navigation program that supports that feeling of really caring for the whole person and making sure that our patients get all the services they need. And I think, they were too humble to say this, but the program that they've built in Brooklyn really now serves as the model for what we want to do across the entire health system. The integration of community health workers with clinical nurse navigators, with social workers, it really provides a level of support that I think is unrivaled in other areas of our institution, which we are certainly working to improve, but absolutely compared to other health systems. And then lastly, Dr. Leonard spoke a little bit about this, and this wasn't necessarily the focus of the program today, but you heard a lot about the clinical piece of our mission. There is also a ton of research, basic science research, translational research. You heard a little bit about our clinical trials that are a big part of what we do as an NCI-designated comprehensive cancer center. So on this slide, you see a few examples of our disease-specific centers of excellence. And the goal of each of these centers, these are not physical buildings, right? These are virtual centers that are really focused on bringing all of these brilliant experts together on common goals. Before we had these centers, we would find that Dr. Smith was working in their lab on something about breast cancer, and Dr. Jones was working on the same thing in their lab about breast cancer, and those two people didn't even know that the others existed. And so we were finding that we were using resources in a redundant way, and we were not necessarily achieving outcomes at the speed we wanted to. And so these centers now bring all of these experts, these scientists, our clinical trialists, our clinicians together, working on common goals in each one of these disease types. And they are really advancing the care of our patients. Many of the treatments that are being delivered in the clinical setting today were developed in labs just like those, the 23 labs that are part of Perlmutter Cancer Center. So this is, again, part of the future and the focus of where we want to move. And I will turn it back to one of our center directors to talk about one of our other innovative programs.
Actually, before I go back, before I go on to that, I just want to tack on one other thing, because we're referencing the Perlmutter Cancer Center, and again, it was briefly mentioned earlier, but kind of passed over, that the PCC is an NCI designated comprehensive cancer center, which there aren't that many of those. There aren't really others that have anywhere near what we have going on in Brooklyn and working with Brooklyn, and really outside of Manhattan. And I think that's a very special place. You heard Tori earlier and Megan referencing the community outreach and engagement, which is a huge part of listening and engaging with our community to find out what our community members need and what they want and what are priorities for them as far as our mission. We also have Dr. Mark Phillips here, who oversees aspects of our training programs. And these are an important part of our cancer center in fostering the next generation, working with the community so that students and trainees in the entire spectrum who may want to work in health fields writ large have opportunities to get exposed and trained and so on. And so there's really a depth to all of this that goes much beyond just putting up, as Oscar said earlier, putting up a sign on the door and saying, here we are, but really engaging with the people that live and work here and what they need and what they want. So I didn't want that to go unacknowledged. And I think, we can certainly, if you have interest in those areas, I know people would be happy to talk more about that, because those are all obviously two-way streets. So one of the things we're really excited about is the relatively recent arrival of Dr. Sridhar Ganesan, who's leading our molecular oncology program. And more, as patients are diagnosed with cancer, the molecular analysis is essential to their treatment. This can be used to detect tumors. I can tell you from my own family member, a tumor was detected from the blood using one of these sensitive tests when we couldn't figure out where it was coming from based on a biopsy. That leads you into getting patients onto the right therapy, targeted therapies based on molecular subsets, new therapies that only a fraction of patients in some cases can benefit from. But if you don't do the test and interpret it correctly, then you can't get the right treatment. And obviously using this for treatment planning, decision-making, and now a whole nother generation of clinical trials and likely clinical care that will be based on, does this molecular marker change or go away? Can we reduce therapy? Do we change therapy? And this is really something that we're committed to. We're initiating really a system-wide program to essentially bring this to everyone, no matter where you are in the system and diagnosed with cancer, and then, matching with the appropriate therapies and interventions from there. And so this is something I'm sure we'll talk more about. But we know that many people diagnosed with cancer do not either have access to these types of tests, or their doctors don't order them, or it's just not practical for them. And so that's a huge group of the population that's missing out on potential benefits by having more information about their cancer. And we're committed to really delivering this across the community, across the area. You've seen many of the individuals on the next couple of slides here today, and you've seen how great they are and how they're committed and how they're moving the field forward, and really how they're great people, great doctors, people that, we all would be comfortable with our family taking care of, which is what's it all about based on who they are as people and their skills and expertise. And so I think one of the things that is, I think, incredible, and I think is how many people want to come and work in Brooklyn. And I think it's on many levels and are doing a great job. It's the community that Oscar and Brett and others, and really everybody in the room, have built here, of people that are top tier, world-class oncologists, and also great people who are committed to the needs of people in Brooklyn and delivering high quality care and research and compassion, frankly, to the patient populations here. And so I'm not going to read through, because you've seen them in person and on slides, but you look at this GI group, you can look at head and neck, thoracic, you've seen people here today, breast, GWA and oncology, GU. I mean, these are I would say unrivaled, and really they provide care that is on the same level as you would find anywhere across the country. And so I think this is really a great part, and we're not done. We're going to continue to grow. And I think the fact that we have so many great people here is just going to continue to foster the community of people in the areas as we grow. Neuro and spine, hematology, radiation oncology. I'm not going to read through, but you've seen versions of this slide already. And then obviously general oncologists, and that is an important part of delivery to our patient care, to our patient population as well for various reasons. So with that, I just want to thank in particular, really our team, but Oscar for spearheading this along with others. I also want to thank, and one thing, Casey is here with me, but we have a wonderful administrative team, many people in the room here. And I think, doctors tend to think that we can just have some idea and it just happens. And if we're a good doctor, everything happens. No doctor feels that way. But I think the fact that we're able, there's one thing to have a great idea. There's one thing to be a great doctor, but to deliver the care requires a team. And, it's, everyone knows, nurses, social workers, pharmacists, et cetera, et cetera. But if you don't have the administrative team to really make all that happen, you're not going to get the job done. And you're also not going to get great ideas to move things forward. And our team is really second to none. So thank you all as well.